Ooh, the room fell silent. Okay, good. All right. Well, I hope you enjoyed lunch. I did. We are going to have 2 back-to-back sessions, and then we'll have a break. The first is how being disconnected is killing rural Americans. Sarah Jane, all you. I'll hit escape here.
Thanks so much. It's good to see everybody in person, some old friends and some new ones. And it's good to be online, too, for those who are watching on Zoom or watch it later. The idea that being disconnected can kill rural Americans may seem far-fetched to some. Today, our panel will provide the data, the nuance, and the on-the-ground stories to help you understand how a lack of transportation and internet are connected to worse health outcomes and deaths, especially in rural America. Our roadmap for this panel will start with some level setting of what rural disconnection looks like. We have 2 data-rich presentations, Eric and I, and we will talk about what we see on the ground to fuel some quick story ideas for the reporters in the room and for the researchers too. And finally, we'll try to have time to make questions too. The workshop's agenda has our formal titles. They're up on stage, but if you'll allow me just a moment to add just a little bit of color, I'd really appreciate it. I want to start with Megan Waiters. She's the digital navigator out of Alabama. And Megan has been talking to me for more than a year. She has been a go-to source and has not appeared in any of the stories I've worked on in the last year. But when I have questions about what's happening on the ground in Alabama with digital connection, she can answer them off the top of her head because she works in those communities. And then we have Eric, who comes from the University of Minnesota. I know we saw a lot of data points earlier this morning, but if you don't know the University of Minnesota and its Center for Transportation Studies or its other centers of research, it's a must-go-to place for rural data and connection. So I'm very grateful that Eric came down today. So just to sort of open up the framing, I wanted to start with Megan, if that's okay. Megan, you knowing that rural America, we've talked about it all morning, and I'll pause right here and just say, sometimes as Chief Rural Health Correspondent, I acknowledge that covering this beat is often what's wrong, what's wrong, what's wrong. There are many beautiful things about rural America, and there are many wonderful things that can happen, and oh no, we waited too long. Okay, good. But we do want to kind of cover some new territory in this panel beyond what we've talked about earlier today. Megan, you work out of Alabama where poverty is higher than the national average. You spent a lot of time in communities, both in Tuscaloosa and working with libraries and senior centers and community centers and their clients. What is it exactly a digital navigator is? What do you do? Is it on?
Good afternoon. Digital navigators, so we have 3 main purposes. One being to teach digital skills to people that need it, to help, second being to assist people with getting appropriate devices for whatever their needs are, and then the third being assisting people with gaining home internet access or internet access period, and affordable home internet access.
Okay, great. And Megan, I teed you up for this beforehand, of course we talked, but when you go into the communities and you're sitting in a community center or you're sitting at a library, is there one client that you think of that can help explain to the healthcare journalist in this room how important it is to be connected?
Certainly. I've had the honor of traveling and teaching digital skills classes in 11 counties in Alabama. And one of the stories that kind of stands out to me is I have a couple students that are retired registered nurses. And their struggles were they knew how to do their job when they were doing their job in terms of being on computers and the software. But in their everyday lives, they were struggling to locate their email address in their phone. They were struggling to change their passwords in their email address, struggling to get logged on to learn the digital skills. And it was a challenge for many of them because they're retired And so they've done the work, and they finished, and now they're just struggling to be able to transcend in this digital space. And so for those clients that I saw, I was able to do skills assessments on them ahead of time. And so I understood what their comfort levels were in terms of searching on the internet for information, even if that was in regards to their own personal healthcare needs or medical concerns. And so what I've learned is sometimes people are really good at doing their jobs because we kind of do that over and over again every day, but we struggle when it just comes to everyday things that we may not even think about in the digital space. And so those stories with those registered nurses always stands out to me.
One of the things I think about when you talk about getting onto email and being comfortable with that sort of online system is the importance of online portals for healthcare providers. And so these folks that you helped learn their digital skills, were they able then to use those skills to then connect to healthcare and get better care possibly?
I would say those students that had that as a personal goal from the beginning to be able to access their healthcare concerns, I do believe that majority of those students were able to get what they actually came into the class to get in terms of learning what they needed to do to navigate the digital space concerning healthcare and their medical concerns. Trying to bridge two stories together in my mind. Sorry.
I wanted to ask you this question later, but I know you've just worked on a grant application fulfillment. What are just the age groups of the folks that you've worked with over the last year?
Yeah, so I have had the honor again, and I say honor because it is a privilege to be able to provide these services in the communities because there is a need. And so I had the honor of my youngest client was 7 years old. My oldest client has been 91 years old, and I actually had two that were 91 and about 5 that were around 85 to 87.
Yeah, and we'll get into the details of that in a little bit. I want to go to Eric now and let Eric sort of talk a little bit about what he works on. You're at the University of Minnesota Center for Transportation Studies. I'm going to hand off to your presentation in just a second, but first a question. What is it about transportation that impacts health, particularly in rural America?
Thanks. It's nice to be with you all. So transportation has come up already sort of obliquely this morning, and when we're talking about access, that encompasses tons of different dimensions of connecting people. And access can be digital, it can be a payment process, it could be a website as we were hearing about, but it often is physical connection, right? So moving from the origin to the destination. And so that really fundamental connection between where you are and the destination you need to get to is often what defines rural America. So when we started this morning with the different kind of categories of rural and how rural can be defined in different ways, the way I think about rural being defined is actually a transportation definition. Like a rural area is a place where it's harder than other places to get to what you need.
Great. Well, I'm going to ask you to come up here and explain some of the amazing research he has done on those transportation issues in rural America. Then afterwards, we're going to connect the dots between lack of transportation, lack of connectivity, and what all that means.
Thanks again. So yes, I will give a brief overview of the types of things that we do in transportation, thinking about this connection. We study what we call accessibility, and this is a word that has a lot of different meanings in both health and transportation. When we're talking about it this morning, I'm going to use this transportation definition, that accessibility is the ease with which people could reach the destinations they value. And the two italicized words there, ease, we're measuring some kind of cost or barrier that you have to overcome. And then could, an important thing here is we're measuring what people might do, so the possible opportunities that they could reach, not what they are doing. So this is not like travel behavior. This is more like what is the universe of things that people are choosing from, for instance. So we try to measure this. We essentially do a bunch of trip planning. So we actually look at the geographic origins where people live, and we think about the geographic destinations they want to get to and the different ways they can get to it. And we do that thinking about two things. One is choices. We always put this in a choice framework because people do have choices. The universe of choices is not available to everyone. And certainly thinking about rural areas, you could say, well, maybe there isn't public transit available. Maybe there aren't ways to safely bike between origins and destinations. Maybe the distances are too far to walk or roll. But of course, the biggest marker of choice in pretty much our whole country, urban or rural, is whether you have the ability to drive or operate a car. And not everyone has that choice. Certainly people that are under 16 or over a certain age where they can't see very well anymore. If you have trouble getting certified for a driver's license, if you have a broken right foot, you can think of all the different reasons why you can't drive. What is your access in that situation? So we put it in terms of choices, and then we also measure costs. And costs are monetary, but often they can be things like time. And this is true especially in rural transit, thinking about the time needed. You need to schedule your trip 24 hours in advance or more. So thinking about things like cycling might be thinking about safety, and certainly with automobiles, the cost of fueling, insuring, operating, maintaining a car is not negligible either, and of course is going up like everything else. Okay. So we essentially do this for the whole country. We start with the census block, which is the smallest grain of the census geography, and we take the middles of those blocks and we use those as our origins. So we have 8.5 million origins that we start with, and from all of those origins we do trip planning. Basically everywhere you can get to in a certain amount of time using a certain mode. We do this for driving, for public transit, for biking, and for walking. The basic idea is you can draw this little boundary of where you can get to in a certain amount of time and ask what's inside that radius. But the radius is not a circle, it is the actual movement on the network. So your drive time, your walk plus transit time, whatever it might be. Most of the time when we work with these data, we think about, and I should say we're being sponsored to do this work by departments of transportation. There's 12 of them we work with across the country. Not Georgia, unfortunately, but maybe someday. And their main interest has been economic connection. So the first thing people ask when you calculate accessibility is kind of like, what jobs can you reach? How many jobs can you reach? So that's a very common metric we use. I pulled some of our data for Tuscaloosa County, where Megan has been working, and I don't know anything about Tuscaloosa County, but I bet Megan could talk at length about what this map represents. If you look at this, it's showing you where jobs are reachable within 45 minutes drive time in a typical weekday. Okay? And so on the right, eastern border of Tuscaloosa, those people are able to reach Birmingham, basically, within that 45-minute drive, and the rest of the county is not. So that shows you where sort of the economic connections of transportation are located in this county, and I'm sure that that also reflects some of the health challenges that are happening in the blue part of this county, which would be the lower access region. So we also calculate destinations, access to destinations of other kinds, and I'm going to focus with two quick vignettes so as not to take too much time thinking about, first, access to food. We've heard about the SNAP program already this morning and the challenges of access in terms of getting certified to use SNAP benefits. I'm going to talk about traveling to a SNAP retailer. And then the second one is about access to trauma care. Both of these are in the context of Minnesota, where I come from, and the short version of the geography of Minnesota is Minneapolis-St. Paul urban area, and everywhere else, which we used to call sort of outstate, is different forms of rural. And they're very different, as you'll see in a minute. So this is a map of the grocery and retail locations who accept SNAP benefit payments. And what we did was measure the typical access to those using different modes, especially thinking about people who are not using a car. So we measured how many people could walk within 60 minutes to the nearest grocery retailer and looked at that travel times. Huge sections of gray in the middle of the state represent places where it would be more than an hour's walk to get to a grocery store, so we stopped counting at that point. Biking is a little better, but you also have to consider where it's safe to bike, and so this map reflects kind of an approach where we're calculating the travel time on protected or kind of safe bike networks. And again, there's a lot of challenges throughout the state. We did notice, though, that there are some places, and thinking about how it's not all about problematizing rural areas, there are some rural areas in Minnesota which have nearly as good grocery access by foot as some of the urban counties in our state. And when we kind of zoomed in on that, what we found was these places, sort of highlighted in these red colors, are towns that grew up along the railroad that was developed in the 1880s to service the agricultural economy. The same economy is going. Most people live close to those towns and so have reasonable access to their nearest SNAP retailer. And comparing it to the urban areas, they actually compare really favorably because of how people and destinations are next to each other. So that may seem sort of straightforward, but it's one of the ways that defining rural can be sort of complex, because those are definitely rural towns. There's not much around each town, but to the extent that people are embedded in the towns in their life, they have really good access to what they need. Okay, then the second vignette I wanted to go back to is actually thinking about transportation as a health risk itself. Minnesota has a lot of roads that service these rural areas, and that has been wonderful for us as an economy, and it makes traveling across the state much easier than maybe it otherwise would be. It also helps that we're extremely flat. But with that comes a risk, which is, again, thinking about rural areas as being dependent on longer than average auto trips. Each mile in the auto carries a risk of fatality, because this is the number one sort of early mortality source in our state and our country is traffic fatalities. And we've, of course, have had a goal of reducing those fatalities year over year and have not managed to achieve those golden numbers that we were looking for. So what we wanted to do was calculate this risk, thinking about the movement that happens after a crash on a roadside. And the way we did this was to sort of look at all of our ambulance service areas, which are all these little shapes on the screen. They're responsible for certain jurisdictions, right? And it's not always the same as the county boundary. And we measured how long it would take to get from that ambulance depot to the roadside where a crash might happen, not has happened, but might. And then from there to the nearest trauma center. So what that looks like is, again, we sort of do these trip plans of how long does it take to get from that little ambulance at the center of the screen out to each dot along the roadside. And then we look at the travel time from all of those places to the nearest trauma center. We're showing a lot of dots on the map here. Again, something to be thinking about is, you can calculate this for existing destinations. What happens as some of these trauma centers blink out with lack of funding? How does that change the situation? But so we can map those travel times. As you look at travel time to the roadside from the ambulance depot, the yellowish color to orange is kind of less than 30 minutes. That's pretty reasonable. We have pretty good distribution of the EMS to get to the roadside. But when we look at the travel time to the hospital, to the trauma center, the reds and oranges here are 1 to 2 hours of over-the-road travel. And when you're talking about response to a very serious injury, that's too long, basically. So having a 2-hour response time to get to anywhere where you could be stabilized in a trauma episode usually has a really bad outcome. And the statistic we had heard from our colleagues in the transportation department is something like 40% of the people who die in a crash were alive when EMS showed up. So that post-crash care is an extremely important part of reducing those fatalities. So that's kind of the story as far as connecting things. On the front end, we have transportation to these daily essential needs, and we've done similar things with clinics and other preventative care as well as the food. And then on the back end, thinking about these emergency services, both of them share the characteristic that in rural areas, the destination density controls the travel time. And so as we lose those kind of facilities, it's really going to impact people in a big way.
Thank you. I do have a quick follow-up question for you on that. And that is it true that rural residents are more likely to rely on private transportation rather than public transportation? So when you're talking about getting to that SNAP location, that's going to be more challenging in rural America? Is that correct?
Yeah, I think stereotypically, the transit provided in rural areas is a lot less sufficient than what is provided in urban areas. I would personally make the argument that the transit in the urban areas isn't as sufficient as we would like to think either. But there's definitely a difference as you're in rural areas. For one thing, a lot of counties, and I'll just speak about Minnesota because that's what I know, counties kind of determine what they're going to provide, and some counties limit it to certain populations or certain characteristics. Some make it more universal. And so, yeah, that if you do not have a ability to drive your own vehicle to where you need to go, the options become much more limiting in rural areas. Yeah.
Right. Okay, so now I'm going to do a presentation, but I actually mentioned this to a couple of people, so I can't forget to do this. It's after lunch, and I brought candy to pass around. It's not approved by AHCJ and will cause, is not healthy. So I'll
That's the benefit of attending in person and rather than online then, right?
Yeah, sorry people online. It's after lunch. So I'm Sarah Jane Tribble. I'm the Chief Rural Correspondent for KFF Health News. I've been in that position for several years now, and it's my great honor to work with our team. And we are spread, the health team is spread across the U.S. In Iowa and Idaho and Michigan and elsewhere, and we're expanding. So it's been an honor to work with them, and I get to do a lot of great stories, which I'm going to talk a little bit about now. When Catherine called me about this presentation, I thought to myself, well, I've been working on a project for the last year about connectivity, so I can certainly talk about that. I have not been working on transportation, but I'm very aware of the transportation challenges in rural America, and I think Eric's done a great job connecting the dots there. Return? I'm sorry, it's not going forward. There it is. Okay. So I'm from rural America, just to start off with. I grew up in southeastern Kansas, and I've spent a lot of time there in recent years working on some stories as well. So I come with rural America bona fides. I really understand it. My parents still live on the gravel road that I grew up on. I don't know how to work this, evidently. Sorry. There we go. Okay, I figured it out. So why does rural America matter right now? Why are we all sitting in this room? We've heard a lot about rural America in recent months, and I was talking with Brock Slavic a little bit earlier, and I feel like rural America is sort of having a moment, right? It was a big discussion when we were talking about H.R. 1, the big, beautiful bill, whatever you want to call it. And then coming out of that bill, there was this historic investment in rural health care, the $50 billion Rural Health Transformation Fund that was mentioned earlier today. It is $50 billion that will be handed out beginning at the next year. And states have to apply for half of it, and there's all sorts of details that we could talk about on that. So rural America is sort of having a moment, but it also matters from a political spectrum in all the states because because of where we are in our divisive politics in the U.S. You also heard about hospital closures. So when you talk about rural America, the first thing you hear about is hospital closures. Why does that matter when you're talking about transportation and connectivity? Well, if your hospital closes, obviously it's going to take longer to get to health care. Often when those rural hospitals close, doctors leave the area, and there's, all the things that you would expect to happen. I have the UNC Sheps Center map up here, including a map as well from KFF on Medicaid expansion states. And just to note that places that have not expanded Medicaid do often have, research shows that their hospitals aren't doing as well financially, so they're more likely to have closures of services or hospital closures. The UNC, University of North Carolina, Chapel Hill Sheps Center is a go-to resource. At the end of my presentation, I'll have a QR code with one of my handout sheets that will have links to many of these sites on it if you want to download that. I'm going to do a shameless plug on rural America. We've been talking about hospital closures. Brock's smiling because he knows what I'm doing here. So I did the first narrative podcast for KFF Health News, and it is about a rural hospital closure in southeastern Kansas called Mercy Hospital, and it's 7 episodes that follows different issues, including what happens to somebody who falls and hits their head, and the ambulance comes, and he dies before he gets to care, basically. So there are episodes that kind of explain many of the themes you've been hearing about today. I'd be honored if you listened. Fast forward. I work on this series about the rural hospital closure, and I'm doing stories about rural hospital closure. I come back to D.C., and everybody's talking about telehealth. It's 2020, and Trump signs an executive order saying that rural health matters, and he thinks telehealth and technology can help improve healthcare in rural America. This is during Trump's first term. In 2021, the Biden administration passes the Internet for All Infrastructure Investment and Jobs Act. And this is a slide that I'll probably come back to while Megan's talking, because what this act did, it passed $42.5 billion in broadband equity access and deployment program. That is a program that basically has infrastructure going into areas of rural America where they don't have high-speed internet fiber lines. And it was a fiber preference program because fiber costs more up front, but it tends to last longer, according to the experts. The Infrastructure Act also put in a program called the Affordable Connectivity Program. So this act had 3 tiers. Infrastructure, helping people be able to pay for their devices and pay for their internet, and also the digital equity grants. So the 3rd tier is exactly what Megan has been working on, which is once you get it built, once you have people who have access to it because they can afford it or have the devices, then you still have to help them learn how to use it. So it was really a complete package of helping train and get rural America online and get the access where they didn't have access. The Trump administration comes back in 2025, and immediately the program is put on hold and pause. The Commerce Secretary, Howard Lutnick, says that it is full of woke mandates and agenda items, and they're going to have to pause it and review it. So they paused the infrastructure program. It's now getting back online. States are reapplying for it, and Trump announced that he believed the Digital Equity Act was unconstitutional and has canceled the funding on it. That brings me to the project I was working on before the Trump administration came in, which is Dead Zone. When I was working on the No Mercy project, Where It Hurts, and going to southeastern Kansas, I would hear from the community members, well, we got 5G, you should be able to get online. I found myself sitting outside a local library trying to call into NPR's editor, Scott, and read a script to him because I could not get internet anywhere. My parents didn't have high-speed internet. It was either McDonald's or the library. And I should frame this because I was going home, so I'd spend like 4 or 5 days in the community where the hospital was, about an hour north of my parents' house. So then I would go and work from my parents' house and spend time with them. But they didn't have internet, so I would either go to Pittsburgh State University in Kansas to use their internet, or I would go to the library or McDonald's. During this project, I realized that everywhere I was going, people didn't have high-speed internet and how it was affecting. I was like, if I have to sit in my car, my parents can't access an online portal, how is this affecting their health care? And that was the big question I had. So I came back and I pitched this project. KFF Health News decided to do it. We reviewed FCC broadband maps. We worked with George Washington University's Mullen Institute on provider data, both on primary care providers and mental health providers. And then we also overlaid some other data. You can see the project there if you want, but I'm going to tell you a little bit more about it. The top 5 takeaways: nearly 3 million Americans, more than 200 mostly rural counties, lacked all 3 things, which we call dead zones. They lacked sufficient high-speed internet, sufficient number of Medicaid primary care providers, and a sufficient number of behavioral health providers. So if you're lacking those providers and you're lacking high-speed internet, can you do telehealth? 123 of the counties were without hospitals. The epicenters for the problems we were seeing were in the places you would expect. And one of the big takeaways of our project is that residents in these counties are correlated with living sicker lives. They have poorer health outcomes, according to the CDC data that we overlaid, and they die younger on average. I'm going to let you listen to a couple of their voices. Oh, if I can get it to work. Obviously, I'm technologically challenged here. It was going so well. All right. Is it back online? Yeah. All right.
No, my kidneys done quit. I do dialysis. I have no transportation. People don't forgot about me, feel like it. No, they don't want food, no little mess like me. That's what I feel like.
I'm going to play that again. That's Leroy Walker. He lives in Greene County, Alabama, and he is on dialysis 3 times a week. Medicaid pays for his transportation there. And but when he has an issue, he has to go to Birmingham or Tuscaloosa. And there is a hospital there. It just doesn't have the facilities that can help him adequately. I met him in the hospital. He had gone in on an emergency trip because he had been having trouble breathing after a dialysis event. And I'm going to just play his voice one more time.
No, my kidneys done quit. I do dialysis. I have no transportation. People don't forgot about me, feel like it. No, they don't want food, no little mess like me. That's what I feel like. No, my kidneys done.
Okay. And then these takeaways, I want to play the voices from several of the trips I've been on. So you're going to hear from Nancy Eschiff-Murillo. She's a council member and was an elder on the Fort Hall Reservation. She got voted out last year in the last election. Linda Cochran, who is in the pink. Linda's in the blue at the bottom. She's the daughter of sharecroppers and a lifelong resident of Greene County, Alabama, who was very eager to talk to me after I met her outside a library. And then there is Gary Vance in Branchland, West Virginia. He lives on the top of a hill, and he does not have running water or internet or telephone. And then there's Marlo Wolf, a nurse practitioner at the Pineapple Health Clinic in Wilcox, Alabama. All of them live in places that are identified as dead zones on our map.
We're in a survival mode. We're not there to catch that falling star. We're there to do what we need to do to eat. I'm talking about many of our people.
And broadband can help with that?
Yeah. Because of the health aspect. If you talk about health, you've got to be healthy. If you aren't healthy, you're not going to do very well. You can't get a job. You can't do work. Maybe you can't even go to school. The children are hurting. I'm giving you a tough story, but that's it with many of our people.
I love the Greene County. If I went on a trip or whatever, went up north, I couldn't wait to get back home. But now I want to stay away from home because there's nothing here no more. It's nothing here anymore.
And say your name again?
Gary Vance.
Gary Vance.
Yeah.
And you don't have any internet and you have no water?
Nope. And I got high sugar and all kinds of stuff.
Oh, you've got diabetes?
Yeah, I got deteriorating bones.
Why do you
And
mention,
I got lung problems.
so why do your health concerns matter without the water and the electricity?
And you meant the phone? Well, you can't call nobody to get out if something happens. And you got to have water to take a bath.
Yeah, I mean, they matter. Their lives matter. They choose to come here for their health care, and we should have the capabilities to care for them.
Marlo is a nurse practitioner in Pineapple, which is deep in the timbers of Wilcox County, Pennsylvania. And their internet is so bad that when people come in, they try to connect online, but then usually it doesn't work. So you walk into the clinic, and then you can't get there. Even though they've got funds to do it, they just can't get the internet to work because the infrastructure is not there. Gary Vance was particularly hard to interview because of his dogs barking. I don't know if you guys have ever been to like a place, or West Virginia in particular. Everybody seems to have a lot of dogs outside and they bark a lot. So that's what you're hearing there. And you can ask more questions about this later, but I wanted to move on so that we can talk a little bit more. But this is the Broadband Deserts map we have connected to the project. And it has lots of data connected to it that we are fully willing to share with any reporters who want to localize this data, making it local. I'm going to play one more audio for you just because I love her voice. Barbara Williams was the feature of the first story I did for the Dead Zone Project. She has had diabetes for a number of years, and she believes she has it under control. She doesn't want a remote monitor. She doesn't have high-speed internet at all. It's more like dial-up, really slow internet. So she couldn't actually use her phone to download her data and share it with her doctor, which is sort of recommended practice now in today's world to manage your diabetes, which is a very difficult disease to manage. But I'll let you hear her voice.
I stay on top of my diabetes. I know what's right and I know what's wrong. So no worries. I'm gonna live till I live out.
What I love about Barbara the most, and actually almost everybody I meet when I'm doing stories, is I think a very important point after our day of talking about rural America. I don't meet victims. Nobody's a victim. They don't want to be a victim in rural America. They're dealing with the circumstances handed to them, and they're dealing with it the best they can. And so when I, as a reporter, go out, what I'm interested in doing is knowing and understanding the circumstances they're dealing with, knowing and understanding how they're dealing with it, and then asking, wait, how did it get this way? Who's responsible? Who's accountable for this? Which is what we've done with the Dead Zone story and a lot of the stories we've worked on.
I stay on top of...
Oops. So, Dead Zone counties. If you take a closer look, these are some of the counties that you can find data on. And what we do is we have a drop-down on the map online, and you can say, okay, I live near this place that I know is rural. I'm in Michigan, and I know that there are hospitals that have shut down in the last 10 years, and I wonder how that county's doing, and if they have connectivity to do telehealth, which Michigan actually has pretty good telehealth access. But you can go to the counties and download them, and this is sort of a list of some of the worst. You see many of the counties that you would expect in Texas, Arkansas, and so forth. This is an example of drilling down in Alabama, which I went to Alabama 3 times over the course of a year, 2 times for reporting projects, 1 time to see a friend for her 50th birthday party. Very different places, very different places. But for the reporting projects, I went back twice to Wilcox and Greene counties to talk to those residents. Because often people who are underserved and who haven't been treated well don't trust you immediately. You've got to show up and be there. You can see the data points on the slide of what you can get from our data. This is a spreadsheet I put together to share with reporters if you want to give me a call and you're interested in writing about the lack of infrastructure funding going into your state. There's a $42.5 million BEAD funding that I mentioned earlier. The states are now having to reapply for those funds if they were finished with it. West Virginia, Louisiana are a couple of the states that had been finished with their bidding process, had already found their companies, and then they had to redo it. And so you're going to be hearing about that if you're watching infrastructure. If you want, I'm happy to share the spreadsheet, happy to share sources. Finding news and trends for your stories. Coming back circle to the hospital closures. We have a map showing the hospital closures overlaid with some of the county problems. There's always an interesting story in communities that have lost health care. And then the $50 billion fund that we mentioned earlier. Big emphasis on digital and technology solutions. States will get application guidance, I think this month. Brock can talk about it later if you want. And already a handful of states are looking for, consultants and stuff. So there's stories to follow about how states are going to be taking care of their rural communities if you want to look into that. There's a link to my tip sheet and my information if you want to contact me. Before we run out of time, I do have two amazing people here on stage with me. So I do want to ask a couple more questions before I let you guys ask questions. Or if you want to start standing up and asking questions, you can. It's going to be more like a conversation. But the Digital Equity Act, I mentioned it during my presentation. I'm going to put Megan on the spot here. President Donald Trump has announced that he would cancel that funding. He's called it unconstitutional. Can you talk a bit about what that funding means to you and your position?
That funding affects not only me, it affects every citizen of the United States of America. I would say to Mr. President, not being connected is killing rural America, because rural America is a part of America, and we contribute to the total of America. And so it affects everything. Workforce. So we have people in rural America that do work. Everybody's not unemployed. Everybody's not sick. Everybody's not uneducated. And so when we level out the playing field and we provide that space of equity, then we're benefiting the whole of America. And so that would be my concerns and how that affects us. I see clients from every age group, every ethnicity, every gender, even those that identify as other genders or whatever people want to identify these days. And so I'm seeing clients that look like America. And so when we don't have the services that we need, it's really a downside to the whole of America, not just rural America, because the rural Americans do travel some. And so we're going to affect everything that's happening, transportation, workforce, education, schools, healthcare. So it matters to me, and it matters to the people that I serve.
I'm going to tell them something you're not saying, and that is that, the Digital Equity Act went out to different groups that applied for grant funding and so forth, and Megan's job is connected to that act. The funding to pay for her job is connected to that act, and the funding has been canceled. Mm-hmm. So I just want to go back to the slide I had showing this. So when it comes to internet connectivity, what you're seeing is the funding for the states to build infrastructure having been delayed 6 months to possibly 2 years, some states told me. The Affordable Connectivity Program was not refunded last summer by Congress. So the funds that help pay for people to get access to the internet and to devices is gone for low-income Americans. There were 23 million households enrolled in that program, and they no longer get that money. And now the digital equity grants that Megan works with are gone as well. So the system that was built underneath the Infrastructure Act is demolished, basically, for lack of a better word. Megan, how many people do you work with on a general? I know you just did a grant application, so how many folks have you served overall?
Overall, I have served 674 clients across 11 counties in Alabama, and I've just been one digital navigator, and that's because of funding. So we were only able to hire one digital navigator. So 674 clients. I've taught 117 digital skills classes in the last year. I've distributed 648 devices, and I also have skills assessments. So I actually have some data that shows how comfortable people are before they receive a device, before they learn any digital skills. And then I also have a skills assessment on the backside after they have received those services. And so it's a pretty big footprint that we've made in West Alabama. And we're hoping to be able to continue. Of all of these clients that I've serviced, every one of them has asked, when is the next opportunity?
Yeah. And do you have an idea of whether a lot of those clients had transportation or not?
I don't have the actual data numbers for that, but I will tell you that I work out of our housing department. And so when clients come in and they need services, like they need their rent paid, or they want to purchase a home and they're going through our first-time home buyer program, or any of their housing needs, if they're homeless and they're just looking for a place to live, all of these things are online. Their applications are online, and they are struggling for several reasons. One of them, transportation, because many of these clients they're actually able to get to my office, but they don't have a device. And so I have to refer them to our local library. And transportation is a problem in these areas because if they can get to me, they can't get to the next space to actually get what they need.
Yeah, because of the time involved, too, that
Yes.
Eric was talking about. And I do think it's important to mention, most states require Medicaid to be applied to online, SNAP programs online. So if you don't have the literacy and even the actual infrastructure access, think about how challenging that is. And then I see Catherine standing, so I'm a little worried I'm out of time. Yeah.
So we had a question from the virtual audience.
Great.
I'm just standing here for whenever you're ready. Are you ready?
Yep, please.
And I'm pretty sure this is for Eric. What is the right mix of rural subsidies on dial-a-ride and fixed route?
Well, that's a very specific transit planning question, so happy to try to answer that. So, the question is about kind of the efficiency of the transportation in rural areas. What that comes back to is what is the mix of people and destinations on the landscape that you're working in. If it is something where there's towns along the string of a railroad, path, running regular transit along that is straightforward, pun intended. If you're in an area in northern Minnesota which is broken by forests and lakes and impassable, granite, it's very difficult to efficiently move people because the efficiency comes from lots of people traveling at the same time in the same direction. So that's the basic challenge is the low concentration or density, whatever you want to call it, of rural landscapes makes individualized transit really expensive.
Eric, I wanted to ask you a question about something else that you're involved in. It's called Project Reach at the University of Minnesota. Can you tell us a little bit about what Project Reach does regarding transportation and patients?
Yeah, so Project Reach is something run by our Rural Health Research Center at the University of Minnesota. And what it is connecting with people who are doing frontline work of all kinds, sort of some of the things that Megan is doing, but also people that work in food banks or health clinics or other places in rural Minnesota who see a need to advocate for policy change. And our role as academics to help them is basically help provide them some of the data or the information to help with their storytelling. So in my case, I was mentoring a woman in northern Minnesota who runs a dialysis clinic, and their challenges were transportation related, and specifically the regularity of transportation, 3 times a week to ensure, people can stay healthy is a challenge for a lot of her clients who are not able to drive themselves. Or even if they are able to drive themselves, maybe they can drive to the clinic, but maybe it's not a good idea to drive home immediately after dialysis. So our role in Project Reach is all about, shaping that conversation. So I could make a map for her about, what the travel times were in her service area and help explain to, her legislators, basically, this is why we need this increase in dedicated transportation funding, because otherwise we're not going to be able to keep serving people. And the consequence is that they take an even more expensive transportation trip via ambulance to the hospital 2 hours away. So that's the predictable outcome of you not spending money on the transportation up front.
Thank you. And then before I see a question already, I'll just wrap up then real quick and go to questions. But I hope that we've drawn the connectivity lines on why connectivity matters for rural Americans. And we'll start with the questions. Thank you.
In Western North Carolina, we lost 2 labor delivery units, one north of Asheville, which is the urban center in that area, and one south of Asheville. I know of at least one helicopter visit in an emergency as a result of somebody who was bleeding and just couldn't make it to the hospital in time. So do any or all of you have any reflections on disconnection as it relates to maternal care?
I will say on the tip sheet I have a link to Chartis Group. You guys, if you don't know about the Chartis Group, they do rural healthcare research as well, CHARTIS. I think they had the most recent study out on the loss of labor and delivery centers across the U.S. as opposed to just hospitals. Katie, I'm not going to pronounce her last name right, Eric, Katie Cosmo at the University of Minnesota. She has been following, and her team have been following labor and delivery issues in rural America for a long time. She would be my first call if I were working on a story about that. That's my input. I don't know if anybody else has anything.
Yeah, Katie Kuzumano, and yeah, we've been working with her as well, obstetric unit closures, and what we can contribute in our research is essentially what is going to be the burden if Hospital X closes in terms of travel time to people in that community, and the burdens are real, and unfortunately, what we can do is sort of document what that is going to be and not necessarily offer much of a solution. Other than to say that the transportation is not always the best solution. Sometimes it is the placement of the service has to be closer rather than being able to move people.
Yeah. Those are all the, does anybody else have any questions before we wrap up? All right. I think that's it. Thank you so much, you guys.